Good afternoon, everybody. This is Congressman Mike Levin, and I'm very grateful for all of you watching another of our town halls. If you've been watching them over the past few weeks, you know what a great job our whole team has done. I'm grateful to our staff, who's been just so incredibly responsive to the community, and also to our team on the technology side, setting up these video conferences. You probably also know that we're joined each week by a local medical expert, and I am absolutely thrilled to be joined this week by Dr. Robert Smith, who has an incredibly important job always, but in particular with COVID-19 ongoing. Dr. Smith is the director of the VA San Diego healthcare system. We're grateful for him being with us. He's joining us from his home today. He is a San Diego native, and he was appointed as the VA San Diego Healthcare System Director in July of 2016. He's been associated with the San Diego VA since the time of his residency training at the University of California at San Diego, go Tritons, and he's held a range of leadership roles, including Director of Medical Critical Care, Associate Chief of Staff for Healthcare Analysis, Associate Chief of Staff for Research and Development, and Chief of Staff. Dr. Smith is a graduate of Princeton University with a Bachelor of Science in Engineering and of McGill University School of Medicine. And as I mentioned, he went on to complete residency training in internal medicine at UCSD. Dr. Smith, thank you as always for all of your hard work on behalf of veterans, and thank you to everyone that is working there at the VA at the front line of all of this and really risking their own health and their own safety to take care of others and to save lives. We're truly grateful. We've received a ton of questions, specifically in preparation for this week, about veterans healthcare and other benefits for veterans during this pandemic. So we'll answer as many of those as we can over the next hour or so. As always, if you have a question or you'd like to make a comment, you can comment on the live stream itself, or you can email us at mlevin.press@mail.house.gov. Again, that's mlevin, M-L-E-V-I-N, .press@mail.house.gov. And we'll try to get through as many of the questions as we can this week, and we'll queue them up for next week. As I've said every week now, this information is changing very quickly. It's can be very scary. We see the estimates, and we know how serious all of this is. But we're going to get through this together. And I've just been so impressed by the kindness, the generosity, and the strength and resilience of our great communities in North County, San Diego, and South Orange County. Truly, truly remarkable what so many in our communities are doing. And as always, it's so critically important that we follow the guidelines of the CDC, as well as our state and local public health experts who are doing a great job. In previous town halls, every week we've gone through the numbers as they stand, and unfortunately the numbers have gotten quite a bit worse since last week, but nonetheless I will relay them to you. As of right now, the United States has the most COVID-19 cases in the world, as you probably know, sitting at 424,945 and 14,529 deaths. According to California, we have 18,535 cases and 485 deaths. San Diego County has 1,454 cases and 31 deaths. In Orange County, 1,016 cases, just hitting 1,000 today, as a matter of fact, in 17 deaths. In the VA healthcare system, and I'll let Dr. Smith talk about the VA San Diego in just a minute, but system-wide, there's 3,265 positive cases among the veteran population nationwide and 167 deaths among the veteran community. It's obviously so tragic, and this is so much more than just statistics. It's people with stories and loved ones, and it's just so incredibly sad to understand the human toll that this has taken. But we have really, in our country right now, two huge crises that are happening simultaneously, and they're directly interrelated. And that's, again, the public health crisis, but also the financial crisis. And so what we've tried to do in Washington is to address both of those as best as we can. A couple weeks ago, I flew to Washington, and we passed the $2 trillion CARES Act, which you probably have heard a lot about. It has major provisions for public health, $100 billion to hospitals, major provisions for our supply chain, $16 billion to the stockpile for things like PPE and masks and ventilators, $150 billion to state and local governments who need that money desperately and are going to need more money still. And then for workers, it also includes things like direct cash payments for those who are 75,000 or less a year. They're going to get $1,200 in direct cash payment and $500 per dependent. If they make under 100,000, they're still going to get something, not the full. If they're between 75,000 and 100,000, not the full 1,200, but we'll still get something. It's our understanding from our discussions earlier today with Treasury Secretary Stephen Mnuchin that those direct payments, if you're a electronic filer with the IRS, you're going to begin to see those payments next week. There will then be 5 million paper checks each week that are mailed out to those first with the lowest adjusted gross income. In addition to that, critically important that we expanded unemployment insurance from 26 weeks to 39 weeks and added an extra $600 a week to the baseline benefit. So in California, according to the numbers I've seen from the EDD, the Employment Development Department, you're going to go from something like $1,800 now a month now to well over $4,000 a month in potential benefits for the expanded unemployment. Also, the expanded unemployment is now they're supposed to, by the federal policy that we've created, supposed to apply to things like gig workers and independent contractors. I have read, and we're getting to the bottom of why it's taking as long as it is to get that in place in the state of California, but I know they're working very hard at it. There's another big program called the Paycheck Protection Program that was a $350 billion program. We're already adding more money to that. We're talking about adding another $250 billion to the program this week. And what that's intended to do is it's a loan of up to $10 million that would go to small businesses of under 500, and it's really designed to help those businesses just stay afloat and to pay their payroll, to cover their overhead and their rent, basic expenses and utilities for 8 weeks. And 75% of the funds need to go to cover payroll. The idea was that the existing SBA lenders would be responsible for administering the program. So if you're a small business owner, you would go to your existing financial institution and you would ask to get one of those loans. Some banks have been very, very responsive. We know a lot of the credit unions and the smaller and community banks have been doing a great job, and it's sort of a mixed bag among the bigger banks in terms of getting the funds out, getting the applications approved and so forth. But our office stands ready to help. And I encourage anybody who has any issues with any of these programs to contact our office, and you can do so by visiting our website at mikelevin.house.gov, where we also have a whole litany of resources set up to help people understand the programs that are available. I can tell you that we're already working on another bill. I hope that it's a unanimous consent bill, meaning all 435 members of the House would agree. And the idea would be that we would expand the funding for states and cities. We would expand the funding for hospitals, for frontline medical workers, and then finally we would expand the available funding for the Paycheck Protection Program under the SBA, another $250 billion, as I mentioned. We're also talking about a larger bill that's probably a little further out, that would deal with all of that in quite a bit more things like additional direct cash payments, and there have been a lot of discussions around things like infrastructure as well. I think both the president and the speaker would like to see infrastructure, and I would like to see that as well. With regard specifically to veterans, I did want to talk about some of the other things that were in these bills to support the veteran community. There was in the CARES Act, this $2 trillion bill, almost $16 billion in order to support VA hospitals and the community clinics and the emergency rooms. In addition, another $590 million to support veterans themselves who are at an increased risk of contracting COVID, including veterans who are homeless or at risk of becoming homeless, as well as those within VA-run nursing homes and community living centers. Finally, and importantly, another just over $3 billion for VA to modify facilities and expand IT capacity for telemedicine, and to ensure that other programs at VA now can leverage this new technology as well. The last thing I'll mention is we saw very quickly after the my subcommittee that I chair, the House Veterans Affairs Subcommittee on Economic Opportunity, has jurisdiction over the GI Bill and a number of other things. And very soon after we saw some of the orders that were coming in terms of stay at home and social distancing and all the rest, we saw a number of educational institutions close down and go online. And the GI Bill at the time, the benefits were not equipped to square up with that, with the distance learning. So we passed very quickly, and working across the aisle with my colleagues, the House and the Senate both passed on an emergency basis the ability for the GI Bill benefits to cover distance learning. And we were really proud of that. And then finally, we passed something in the House that's pending in the Senate, the Student Veteran Coronavirus Response Act, which builds on that bipartisan work that we passed previously to ensure that student veterans will not see a reduction in their monthly housing allowance as a result of their schools moving online. We've also been working to eliminate co-payments for testing and medical appointments for veterans. And we've been receiving continuous updates from Dr. Smith in the VA in Washington as well about all the things that they're doing. I would encourage everybody, if they're interested in the work we're doing on the House Veterans Affairs Committee specifically, you can go to veterans.house.gov. And before I turn it over to Dr. Smith, I just want to thank him for really being a leader in our community. There's so much information out there that is coming from the feds, the state, the local government, our counties. They're all doing an amazing job. It's so critically important that we follow those guidelines and that we just use good common sense at the end of the day. And our public health experts have said it time and again, but let us all take this opportunity to treat each other with kindness and compassion and generosity. I was on a call this morning with some of our nonprofit leaders who are just doing amazing work. And let's all just look out for one another. If you have friends or family that you think are at risk, make sure you're looking after them, you're calling them, you're seeing how they're doing. If you're worried about them, obviously, we've all got to come together. Just the same, having young kids myself, maybe you'll hear them before the end of this, 7 and 6 years old. We always tell our friends and our kids' friends, if you got firearms in the home, please keep them locked up. My wife reminded me how important that is, particularly now when so many kids are at home. Please do that. But with that, I'm very grateful to you, Dr. Smith, for joining us and for your leadership. And we'd love to hear more from you about what's happening at the San Diego VA.
Happy to provide that. First, thank you, Congressman, for having me on today. I appreciate the opportunity to be able to communicate with the listeners on your town hall as I try and do day in and day out. Really, a lot of this is about communication. It's making sure that the message is getting out to people about why we're doing the things that we're doing, and the impact on the healthcare system if we don't do those things. So let me give you a little bit of a rundown of what's been going on at the VA since really since January, but certainly getting more ramped up in February, March, and now April. We've actually had our incident command system running since mid-February, where just tracking the course of the coronavirus as it began to crop up in the United States, and certainly as it became apparent how some of the healthcare systems in Italy and elsewhere had been overrun because of the way in which the virus had first appeared there. And I think that really gave all of us in healthcare a pause and made us really step back and think about how we would approach that. And so we and others have been very aggressive at trying to make sure that we have all of the resources at hand that are necessary to take care of patients as they come in with coronavirus and to set up enhanced capacities to make sure that we can address what was initially a surge that was thought to potentially occur in the first week in April or even the last week in March, but which has actually been somewhat slowed off or spread out and slowed by some of the things that have taken place in San Diego and in California in general. So we have really been working to, again, assure enhanced capacity. So we've canceled not all, but we've canceled face-to-face visits that are not urgent. We've canceled non-urgent surgeries and procedures, and have really worked to shift our care even more aggressively towards telehealth and virtual care modalities. You and I know many of your listeners know the VA has been a leader in telehealth and advancing telehealth across the country. A lot of that is because we're taking care of a population that is really spread throughout the United States. And so we need to be able to reach out to individuals who may not be close to a medical facility or even to a clinic. And we do that with telehealth at baseline. So all of my primary care physicians and all of my mental health docs are actually provisioned to be able to provide telehealth care. And we have been accelerating our efforts to provide telehealth in specialty care areas as well. We were already doing it in many areas of GI and endocrinology and others, but it gives us an opportunity to really push that even further. So far, we've actually reduced our face-to-face visits by more than 75% as we've shifted over to telehealth and virtual care. Early in the process, I think we had a lot of our hospital beds that were taken up by individuals who might have had coronavirus. So those were sometimes called PUI for persons under investigation. But that was in large part related to testing turnaround times that were not what anybody wanted early on in the process. And those turnaround times, which were sometimes 4 to 7 days early on, have improved dramatically. And we are now having test turnaround times that are sometimes less than a day with quite high throughput. And I really would say that that's not just unique to the VA, that all of the healthcare systems in San Diego and Orange County and LA have really been ramping up their capacity, and that now reagents for those tests have been coming online. And it's interesting as we go through that the bottlenecks tend to shift from one area to another. Early on, our testing throughput was longer than we wanted. Now that the testing throughput is improved, we're finding bottlenecks sometimes in the supplies of test kits. But again, we're working with really people are stepping up left and right to try and provide solutions to healthcare and to try and meet some of those gaps. So we've got some folks that are helping us with 3D printing of some of the test swabs, and we're doing validation right now to move those into a production environment. And again, those are things that are not unique to the VA, but are happening at other hospitals in San Diego, at UCSD and Sharps and Scripps and Rady's and others. So our backlog in testing is now gone, and we've actually been able to really focus our use of supplies on those that we know have coronavirus or that are at very high risk. So far, 22 veterans in San Diego have tested positive for coronavirus, but that's out of more than 500 tests that have been sent. So actually our percent positive of testing is on the lower side, which suggests, again, that we've been aggressive with testing and trying to identify people early who may have the virus and begin to assure that they're self-isolating and that treatments are available for them and following them very, very closely. We're not quite there yet. We've actually been doing some limited drive-up testing at some of our locations, but we are planning to implement drive-up testing in more of our locations to, again, give more people access to testing earlier in the disease process. And again, partly to reinforce the whole notion that what we need to do right now is to slow the spread of the disease. It's a highly transmissible disease. And the real concern up front was that if we had a lot of individuals presenting with coronavirus at one time in hospitals, that the hospital systems themselves would be overrun and unable to keep up, and we'd end up having to ration elements of care. I'm really happy to say that looks to be not the case, and that the efforts in San Diego County and LA County and others to encourage and enforce social distancing, to really have people stay at home, as challenging as that is for everybody. I think everybody's getting a little bit of cabin fever right now. But those actions, those steps that people have taken do look like they are making a difference. I'm very encouraged by the daily numbers that are reported in California, and in particular in San Diego County, where the number of new cases of coronavirus per day has been fairly flat and even potentially dropped off a little bit in the last few days. And so that flattening of the curve would suggest that the steps that have been undertaken may be able to have stopped that surge of patients from coming in. But again, we need to be careful, because we know from viral pandemics in the past of 100 years ago now, that towns or cities that relaxed their guard too early then saw a secondary surge of patients that came in and caused both significant morbidity and mortality in the population, but again, had the potential of overwhelming the healthcare system. So if there's one message I would say to everybody listening on the town hall today, it's wash your hands. Do it regularly. Do it more than you think you should. And really, again, try and keep up those rules about social distancing and limiting interaction. We are going to get through this together. Those things are making a difference. Again, part of my mission here is just to get that information out to people. One thing I would say is I think everybody may have heard that all of the public health authorities are really now recommending that as you go out, you wear some kind of face covering. Sometimes people don't understand the purpose of those face coverings. It's less to stop you from getting coronavirus, although it does have that role, but it's really to stop asymptomatic spread of coronavirus. That is, we know more than we did a couple of months ago that a significant percentage of individuals with coronavirus may be transmitting the virus without symptoms. And so by wearing a face covering, we can limit that from occurring in those instances where people are out and about. I think I should probably stop there and really get to the questions that your listeners have and answer any other specifics. Otherwise, I'd probably be just talking for 15 minutes or 20 minutes.
Well, we're very grateful that you're here with us, and just want to express again our gratitude to you and to everybody that works for you, with you at VA for all of their excellent work on the front lines of this. We've got a ton of questions. We'll get through as many as we are able. And again, if you've got questions for us, please email us. Again, that email address, mlevin, M-L-E-V-I-N .press, P-R-E-S-S @mail.house.gov. And so we'll jump right in. First from Kathleen in San Diego. She asked, with so many veterans in San Diego, where should they go to get the grants? Well, Kathleen, depends which grants we're talking about, but there are a lot of resources that are out there. We have them all up on our website. If you go to mikelevin.house.gov, there's a COVID-19 resource page. Of course, there's everything from the direct cash payments to the expanded unemployment insurance to the small business grants and loans that are available. And that's all there on the website. If any questions or need any help with any of that, let our office know. And our number is right there on the website as well. The VA is processing, as far as I know, all benefit payments as normal. That includes everything from disability, pension, education, et cetera, et cetera. And as I mentioned before, we were able to expand the eligibility for the distance learning so that people's GI Bill would work for that also. But keep us posted. A shout out to Andy Ortega and Gabby Ochoa in my district office, both of whom are veterans themselves who handle our veteran and military outreach. And we're so grateful to both of them for all their good work. And I would imagine they're watching. So we thank them. And please take me up on the offer of our office being of assistance to any veteran, really any constituent that needs to help, but we really pride ourselves on helping our veterans. An anonymous question. For you, Dr. Smith, I haven't felt the need to use the VA's mental health facilities in the past, but now, social distancing and the state of affairs, I feel the need to reach out or speak to someone. What resources are available for a new patient wanting to use mental health during this time?
Thank you for that question. So I'd start by saying that the VA has a crisis line that anybody that feels like they are really in extremis or you need some help right away that second, I would call the crisis line. That's 1-800-273-8255. But beyond that, the VA, as I was saying before, really does have very robust telemental health capabilities. We have a telemental health hub that's located in one of our facilities in the Old Town area. We have staff who are available to provide mental health care to those that need. Our mental health scheduling number is 858-642-3391. And I'll make sure those are posted later. But those are, you just call and ask for an appointment. Certainly, if you're already in the VA system, you could have your primary care doc or your existing mental health provider. Just send them a secure message and reach out to them, and they'll be more than happy to talk with you either on the phone or in a telemental health virtual chat room, and really make sure that your needs are addressed. And I would say that one of the pieces of information that we knew already, but has been even made more evident with what's going on right now with coronavirus, is just how effective telehealth can be. Some of the research that was done that actually showed the equivalency of telemental health care with direct face-to-face mental health care was done in San Diego, and we've really been out ahead of that curve trying to make that available to people. Even before coronavirus, we had veterans who perhaps had severe PTSD and felt uncomfortable getting out in public, and being able to provide that care for them in their own homes was really a game changer for many of them.
Thank you, Dr. Smith. Jan in Encinitas asks, I'm a nurse and an epidemiologist. I am deeply concerned about the inevitable outbreak that will occur at jails, prisons, and among detainees across the nation. What is being done about the Vista Jail and other facilities within our district? Jan, excellent question. According to the Sheriff's Detention Services Bureau, they're following all the CDC guidelines. They've assured us that they're doing that to ensure that the inmates are staying as healthy as possible and as safe as possible, and their employees as well, everyone working there. I know that from our district office discussions with them, that they've enacted processes to quickly and safely isolate those who are potentially ill away from the rest of the community there to reduce the likelihood of community spread. And as of Monday, the San Diego Sheriff's Department had 228 beds that were specifically reserved for COVID-related healthcare needs, and that's in addition to the standard medical isolation beds that are available throughout their system. Next question is for Paul, or from Paul, city not provided, and this is for Dr. Smith. What is your advice on eating fresh food, for example, bread and cake from local bakeries? Sounds pretty good. Vegetables such as lettuce and tomatoes from supermarkets, and restaurant takeout. I've seen numerous statements that it's safe, but why would it be treated differently than doorknobs and other surfaces that require disinfecting? Great general medical question for you.
That is a really good question, and it's one that I think people find confusing. What we know about the coronavirus is that it's spread by droplets. Those droplets, particularly if they are coughed or sneezed onto a hard surface like a plastic surface or a metal surface, can condense, and then the virus can be persistent on those surfaces for some numbers of hours even. It's quite easy, however, to swab with disinfecting solution and clean those off. That statement, though, is not true about all surfaces. So paper surfaces, cloth surfaces where the surfaces can dry fully, that actually denatures the molecules, the RNA molecules that are on those surfaces, and the virus does not persist for long periods of time. That's also true of food surfaces to the best of our knowledge, and the data would suggest that food in general is safe. Having said that, I think it's always a good practice to rinse off those things that are washable in the sink. So certainly a vegetable brush or that sort of a thing for fresh produce. Peeling away the outer leaves from heads of lettuce, for instance, and then again making sure that you wash your hands before you do those things and wash your hands after you do those things, so that you're not spreading things around. But in general, food surfaces are felt to be safe, even the boxes and other containers, just because the nature of the virus is that it's not the most hardy beast out there. So I would still encourage people to eat food and bread and fresh vegetables. I think those are good for you.
Got to keep eating, right? Got to keep
Exactly.
eating. Terrence from Saddleback College asks, many programs and courses are being canceled across the state. The May distribution of the April housing allowances may be stopped, leaving many veterans and dependents without the ability to pay for housing and potentially homeless. How likely is H.R. 6322 to pass through the U.S. Senate? Do you have an update on this? Well, first, for those that don't know, and thank you, Terrence, for that, H.R. 6322, that's the bill that I referred to a little earlier in the intro. It's called the Student Veteran Coronavirus Response Act of 2020. And as I mentioned, we passed a very quick bill as soon as we saw what was happening with coronavirus to expand GI Bill benefits for distance learning. This bill would go further than that, and I think it has a really good shot of, if I had to handicap, I think it's going to become law pretty quickly. It's only limited by the Senate Veterans Affairs Committee moving it through the process and getting it passed. I think it'll happen pretty fast. I hope anyway. We passed it in the House. It didn't have any opposition. And it does a number of things. As I mentioned, it allows for VA to keep paying work-study allowance during emergencies for people who can't work. Obviously very important. Housing and allowances are still going to be paid if the school closes during a term due to an emergency. And then it allows VA to restore the entitlement for students that weren't able to move online and weren't able to complete their program because of an emergency. It stops the clock on the veterans' use or lose dates, which I know has been a big concern. And then it expands the benefits not only to the post 9/11 GI Bill, which is what the first bill focused on, the one that I mentioned before, but to all GI Bill benefits and VOC rehab as well, VRE, and that's really important for our veterans too. So again, I think it's going to pass quickly in the Senate. It happened in the House with unanimous support, and I would just stay tuned. And if there's obviously anything that we need to do on the House side to push the Senate, we will do that. Jen, again, City Not Provided, has a question for you, Dr. Smith. She says, it seems like there is very little testing here in the district. Shouldn't we be testing a sampling of people who have no symptoms to see if it is in the community?
So that's a good question, Jen, and thank you. And without knowing exactly where you mean by the district, it's a little hard to answer, but I would say that it's important to reflect on, call it the progression of testing across the country and certainly regionally here in San Diego. 4 to 6 weeks ago, testing was not widely available and it was taking a long time to get results back. That has progressively improved. And I think now testing generally has fairly rapid turnaround, 1 to 2 days, sometimes shorter. And all of the healthcare systems are seeing the availability of what even looks like 1 hour and certainly same day turnaround times for certain things. As those tests have become more widely available, the emphasis has shifted from testing those who were at greatest risk for having coronavirus, COVID-19, to a broader sampling of the population. That still is not quite at the point where I would say we want to test asymptomatic individuals. And the reason for that is that getting a negative test result in somebody who's asymptomatic doesn't mean that they won't get the coronavirus in a week or 2 weeks or 4 weeks. So we're still in a position of needing to understand or to focus some of those resources on those so we can help identify those that need to self-isolate and also look at potentially healthcare workers who we need to make sure that they are not in a position where they might transmit to somebody else. Having said that, I think we will be in a position of broadening testing fairly quickly. But there's another aspect to this, which is that testing right now is focusing on those that have active coronavirus infection, typically through measurement of the presence of the RNA of the virus itself or the genetic signal of the virus. There is not yet widespread availability of testing for past infection. And the testing for past infection by measuring antibody levels will actually be really important for understanding, call it the epidemiology and history of the virus, and for knowing who's in fact immune. We do know that individuals that have had coronavirus may be able to donate plasma, and that may actually be therapeutic for individuals with severe disease. And so those assays to measure the presence of antibodies are beginning to be available. And I think when we have those, we'll be testing a broader sample of the population, both who are asymptomatic, but also those who might have had the virus in the past and been asymptomatic through the use of antibody testing.
Excellent. The only thing that I would add based on my conversations, our district basically starts at your hospital and goes all the way up to Dana Point Harbor. And it's a mixed bag. Things are happening not as quickly as I'd like them to, but we're a lot further along with testing than we were even a couple of weeks ago. Clearly the new fast 15-minute tests from Abbott are a breakthrough, and making sure that they're available in the district is really important. UCSD now has the capacity to use those tests. Yep. Not enough, but they've got some. Roche is really ramped up, and I've been really thrilled with the local companies and on the biotech and the life sciences side, what they're trying to do. Thermo Fisher is working very hard on it, and then Quest Labs, which is in South Orange County in San Juan Capistrano, their facility where they're running about 1,200 a day for a lot of the private hospitals and physicians when they send tests out. So it's happening. It's just happening slowly. I was just on with both Memorial Care and the folks in San Clemente, the mayor and city manager, and there's going to be a new drive-through testing facility there on Monday. There's another one just down the street in Rancho Mission Viejo, and then North County, between yourselves doing a great job with the veteran community, UCSD, Scripps, Sharp, and others, and UCSD has really been fantastic in leading the way. So that's encouraging. Let's see. Next would be for Megan in San Juan Capistrano. She says, our family has a high deductible that we are nowhere near meeting yet and would fear having to go to the hospital for treatment if one of us came down with COVID and needed to go to a hospital. Can you clear up whether testing and treatment, if necessary, will be covered, or would we still be billed for copays and deductibles if we haven't met ours yet? Well, this is a sore subject for me, Megan. I think that all of your treatment should be covered completely, and I would have I advocated that before. I'm going to continue to advocate for it on a go forward. We passed legislation that says the test itself is covered, that you don't have to have any out-of-pocket costs. It's completely free, regardless of your insurance status or if you have no insurance at all. I think this is a huge discussion in a larger issue about what the healthcare system looks like in the United States and where we need to get to. One of the things that I was disappointed by was that the administration opted not to open a new eligibility window for the Affordable Care Act as part of all of this. And we did that in California. Governor Newsom opened an eligibility window for Covered California, which runs until June 30th, which is a good thing. There's obviously still costs associated with that. But for those who have no insurance, what we've been told is that some of the $100 billion fund to go to hospitals will in fact reimburse those hospitals for COVID-related treatment for those who do not have health insurance. So we're waiting to see exactly how that's going to be rolled out. It wasn't in the legislation itself, so we were caught off guard by that. We want to make sure, obviously, those hospitals are still getting the full allocation of the resources that they were promised as part of the law. But your point is totally well taken, and we've got to continue to try to do all we can to reduce the costs for COVID treatment and for healthcare generally in the United States. From Virginia, city not provided, for Dr. Smith. I've heard from many veterans about lack of care when it's needed. They often waited hours to try to get help at the VA and often just gave up and left. A number didn't go back after having this happen several times. Tough question. Don't anyone say that we didn't ask any tough questions. Dr. Smith.
Thank you. And thank you, Virginia, for the question. I would hope, but I would hope that was an experience of many years ago. The VA has changed dramatically in the last 5 years, beginning with the passage of the Choice Act in 2014 and more recently with the Mission Act that really provides access to care outside of the VA if the VA is not able to meet timeliness standards. I'm happy to say that the wait times in the VA in general are much shorter than they are in the private sector. We publish those wait times. You can go to our internet site and then look at the links that are there for quality of care in the VA, and it provides our access times and also comparison to private sector wait times when those are known. We do have generally about between 1 and 3 days wait time for primary care and about 3 to 4 day wait time for mental health care. Specialty care wait times really depends on the specialty, but we benchmark ourselves against the private sector, and again, our wait times in general are shorter. So I would encourage any of the veterans who you might be talking about to give the VA a chance again, and let us use some of the newer modalities of care, including telehealth care and others, to make sure that we meet their needs. That's why we have staff that come to work day in and day out. Their only mission is to take care of veterans. That's why they're there. And if it weren't for the veterans that served our country, there wouldn't be any reason to have the VA. So we really do regard it as our mission to reach out and help veterans and to make sure that their needs are met.
Thank you for that, Dr. Smith. Dina, also city not provided, asks, why did Congress not mandate rent freezes, and is this something being discussed in the House? Well, Dina, that's an excellent point. It's something that, frankly, I would have been fine seeing, and I think that a number of us thought that was appropriate. However, we couldn't achieve any sort of bipartisan support doing that, and ultimately we had to vote for what, at the end of the day, was a good bill, but far from a perfect bill. But I was happy to see Governor Newsom take leadership on this. He banned the enforcement of eviction orders for renters that were affected by COVID or are affected. In addition to that, Javier Becerra, our Attorney General, has now been working with the California Judicial Council to make sure that people are not evicted. Obviously, if we have a shelter-in-place order or a stay-at-home order, people need to have a place to stay. And we have to make sure that we're postponing any evictions or foreclosures. The stimulus bill that we passed, the $2 trillion bill, did include a moratorium of forbearance on foreclosures, and that includes any of the federally backed loans that are out there. So that's not all the loans, but a good number of them, whether they're certainly VA loan or FHA or Fannie or Freddie. And in addition to that, Governor Newsom negotiated with most of the big banks a 90-day forbearance period. I think B of A negotiated 30 days, but JP Morgan and so Chase and Wells and a couple others negotiated a 90-day. These are all, I think, very positive steps, but I think we're going to need more, depending on how long all of this lasts. And it's something that we're watching very closely. And then a number of our cities, of course, have also put in place their own municipal moratoriums on evictions. A lot of our landlords out there, I think, are offering grace periods. Not all of them, but certainly a good number of them are. But again, if you need assistance, whether it be with expanded unemployment insurance, direct cash payments, the small business loan, et cetera, please contact our office. We'd be delighted to help. Jane asks of me, She says, I am 71 years old. I have regular Social Security, of course, on direct deposit. My son is disabled 100% and not expected to recover age 45. He has SSI and no other source of income. He lives with me and I count him as a deduction on my taxes. He has his own bank account where SSI is automatically deposited monthly. What will he receive? Is he an individual, counted as a child, or neither? What can he expect? How is he counted? Well, under the CARES Act, all SSI recipients are eligible for the recovery rebate unless they're claimed as a dependent on a taxpayer's return or they don't meet the other eligibility. So unfortunately, if your son is still claimed as a dependent, he won't be eligible for direct payments under the CARES Act. That's another one that I think I wish that more people were eligible. I know that there are a lot of people who are excluded. And another big issue for me was the cap of $75,000 to get the full cash payment, which, living in North County or in South Orange County, $75,000 is certainly not what it is if you're living in another part of the country. So we're going to continue to work on that and continue to try to expand those cash payments. And I personally would like to see them tied to some sort of metric, whether it be the gross domestic product or the unemployment rate, to make sure that we're helping people as long as this crisis is ongoing. Let's see. Anonymous, a question for Dr. Smith. I'm a non-essential employee at the VA hospital in San Diego and should be teleworking to reduce my exposure to COVID-19, but we're told to continue to go into work. Why? Ooh, tough question, doctor.
Good question. Tough questions. I appreciate them. First, telework in healthcare is a challenging area. I do regard all of my staff as essential employees. We need to keep the enterprise working to provide care for the veterans that we serve. So the question is probably less whether you're essential or not, and more about whether teleworking is an option to do the work that you have to do. I would say that early in the process early in the pandemic, the VA was not as ready to provide an expansion in telework as it would have liked. Some of the early direction from VA central office was actually to focus on expanding telework to providers who might be able to work at home if they were infected with COVID, and still be able to provide some level of continuity of care. So a lot of our emphasis on early teleworking, or the initial focus on where we expanded teleworking, was to some of those what are called level 1 continuity of operations plan personnel. However, and I would say that also there was questions about the integrity of some of the national internet gateways that VA uses for teleworking. Those gateways have since been tested and found to be robust enough to allow more people to telework. But again, other bottlenecks sometimes crop up. We had I think it was 12 or 15 laptops to give to people when the pandemic began. And so we've had to really start to work to expand that cache of laptops, or that supply. And I'm really grateful to Congressman Levin and to the HVAC and others in general who passed a bill that provided funding for VA's Office of Information and Technology to be able to go out and get those. You'd think that would be something that would be obvious, but it really wasn't up front. And so again, it ended up being a bit of a bottleneck. That's changed, and I would encourage my employee to talk with their supervisor and see whether we can make use of those expanded telework opportunities, because we have changed substantially in the last 2 to 3 weeks.
Thank you, Dr. Smith. And we're trying to do the same on the House of Representatives side, trying to get everybody the laptops that they need. And our House Administration Committee, Zoe Lofgren's the chair, and just continues to do an outstanding job in helping. But we still have institutional issues around things like remote voting. I know a number of my colleagues would like that, but we still don't have that in place. So like any institution, it takes time, but I'm grateful to hear the progress at VA. Let's see. Ethan in Carlsbad asks, and this is for me, when will the California EDD extend benefits to include gig or 1099 self-employed workers? These benefits were included in the last bill, but it appears California does not have the systems in place to make the law operational. Ethan, that is a fantastic question. That is something that we absolutely have to address. And I'm following very closely, and we're getting a lot of comments because, again, the federal legislation that we passed, the CARES Act, specifically expanded unemployment insurance to independent contractors and to gig economy workers. We did so knowing that different states would have different degrees of trouble implementing those changes. Just as we put in the new $600 in extra unemployment insurance benefits per week, we knew that that would create potentially some challenges as well to implement. In California, from everything I know, the $600 a week has been going okay in terms of the implementation, but expanding the eligibility pool has been difficult. I know they're working really, really hard on it, and my office is in close contact with the governor's team about the implementation, and I hope that any day now that will become a reality for our gig economy workers and our 1099 independent contractors. Nick in Carlsbad asks, for you, Dr. Smith, do we know with certainty whether we can get reinfected or whether we develop an immunity to this virus after being infected once and recovering?
So the answer to that question, and that's a good question, Nick, is that to the best of our knowledge, and I think it's actually quite good knowledge, you do develop an immunity once infected, and you do not become reinfected. There are some anecdotal reports from some of the early literature in China that suggested people might be able to be reinfected. But more and more we understand that those were probably issues with the quality of the testing rather than the ability of somebody to be reinfected after they have been infected once. Best of our knowledge, once you're infected, you are immune. Excuse me, once you're infected and you recover, you're immune.
Got it. Another question, which in looking at it, I think both of us can take a crack at this. It's sort of a policy question and a medical question all rolled into one. Norb asks, when will you, assuming he means me, Governor Newsom, President Trump, and world leaders shift focus to the reality that COVID-19 has a 98% plus survival rate and is a virus we will have to live with while finding a fix, just as we do influenza, and focusing on protecting the most vulnerable, like keeping in place a stay-at-home quarantine for all over 80 years old? It's really simple for me. My vantage point is to trust the science and to trust the public health experts who we hear from every day, whether it be Dr. Fauci at the federal level or local leaders like you, Dr. Smith. The need to follow those guidelines from the CDC, from the state, the county, and our cities in order to flatten the curve, I think is really critically important. And we know it's not going to be forever. We know that the signs are pointing in a positive direction, or light at the end of the tunnel, however you want to say it. And I'm extremely mindful that we've got these two crises in our country, of a public health crisis and an economic crisis. I also believe the only way we solve the economic crisis is if we tackle the public health crisis sufficient where when we do decide to reopen businesses and get people back to work, that we don't have a second wave of infection and mortality. And so I think it's critically important as we look at other countries and how they've adapted to it and how they've put in place policies and procedures, in some cases that have worked, in some cases that haven't. When you think of what our strategy is today, mitigation, keeping everybody at home, doing all these draconian sorts of things, social distancing and the rest, how do we achieve a strategy of containment? How do we go from mitigation to containment? And if you listen to Dr. Fauci or you listen to Scott Gottlieb, who was President Trump's former FDA commissioner, the importance of testing, widespread, readily available testing, to be able to isolate the virus to certain communities, to certain geographic areas, so that others who are not infected and who can be tested and shown to be COVID negative can go back out without fear that they may be at a higher risk of being reinfected. In terms of the, I don't need to get into the comparisons with the flu because I think those have been beaten to death. But I think Dr. Fauci or others would, as they've said, it's far more deadly. The mortality rate is far higher. And I think the real key here in flattening that curve is the line that we're trying to flatten below is obviously the capacity of the healthcare system. And because of the actions that we've taken in California, we're not going to run out of hospital beds like they may in some other places. We're not going to run, hopefully, out of ICU beds. We're not going to run out of ventilators. In fact, I would argue because of many of the early actions we took, we were able as a state to send ventilators to places like New York, New Jersey, and other parts of the country where there is a scarcity. But that's my perspective, and it's informed by the public health community. Dr. Smith, care to add anything to that?
I think you covered the high points that I was going to cover. I do think it's important to point out that even if we're talking about a 2% mortality rate, that for the country as a whole, that would be millions and millions of deaths. And for that to all occur in a very short period of time would be more than the healthcare system would be able to handle. And we already know and have heard stories from our colleagues in some parts of the U.S. and certainly overseas where we have people, 2 patients on 1 ventilator, or where they're having to make decisions about rationing care because of patients appearing all at one time or too many at one time with COVID. So, but being able to spread the curve is in fact doing exactly what Norb suggests, which is trying to find a fix and living with it until we have the solutions like an effective vaccine, which we have for influenza, but we don't have for coronavirus at this time. And so by social distancing, we are in fact protecting the most vulnerable because that's how we stop them from getting infected, by trying to prevent ourselves from being vectors of disease through the community.
Thank you for that. Virginia in Encinitas asks, I know you care about climate change and restarting the economy. Marrying the two by seizing this opportunity to create numerous jobs in the clean energy sector seems like a win-win. What can you do to see ideas like this are included in any new stimulus package? Well, it's interesting you bring this up. To put it in a little bit of context, in the Family First bill, that was the second bill, we had heard that the administration wanted $3 billion in relief for the oil industry. And so we then said, okay, if you want to do that and you want to do the Strategic Petroleum Reserve, we would like also to make sure that those clean energy companies that are impacted by all of this, the solar installations are way down, and obviously other clean energy technologies, that you don't forget about them, that there be the opportunity for them as well. If you're going to take care of energy, then you ought to do it across the board. And as a result of all of that, neither the billions for the oil industry nor any help for the clean energy industry was included in that bill or in the third bill. I know there's been ongoing discussion about doing it down the road. I think the key is infrastructure. Let us focus on those infrastructure projects. Would include modernizing the electric grid, would include rapid deployment of broadband, particularly in underserved and rural communities, would include our water infrastructure. All of those are great opportunities, not only to address things that we know are important for our country, but also will create many, many jobs at a time when we're going to need to put people back to work. So again, from an infrastructure perspective, I see the administration and I see the president talking about wanting to do a $2 trillion infrastructure bill. And I think we in the House, many of us would like to see the same. I think the key is getting Senate Majority Leader McConnell on board with that idea. But your points are well taken. Here's an anonymous, here's another tough one for you, Dr. Smith. I work for the VHA and we're being told to bring our own PPE. Why?
So that is incorrect information, and I appreciate the chance to be able to speak to it. And I would make a distinction between medical personal protective equipment that's used in the healthcare environment and face coverings that are used for kind of general comfort and social distancing measures. So we do encourage people to wear face coverings both outside the VA and in non-healthcare settings. Staff that have their own PPE and want to wear it, we don't stop them from doing it until it becomes a situation where we have a patient in isolation or a patient that needs specific PPE. Under those circumstances, we have the PPE for our staff to use, and we want them to use our PPE because we know where it came from, that it's medical grade, that it meets all of the specifications of NIOSH and OSHA. But we are not telling people to bring in their own PPE.
Thank you for clarifying that. Andy Ortega, he gets special preference in my question order, but he texted me something that he wanted to know that he's been getting asked by our local veterans, and I thought I'd ask. Secretary Wilkie has ordered VA facilities in New York and New Jersey to open care to civilians because those civilian hospitals have run short of beds, ventilators, et cetera. Anything like that happening in San Diego?
So your listeners may not know that one of the missions of the VA is backup to the DoD for national emergencies. That's regarded as the fourth mission of the VA after healthcare and research and education. And so we are part of the country's emergency response system, and we work with FEMA. VA has been tasked by FEMA to identify resources in the regions that we are part of, and to make sure that those are available if tasked. We are not yet tasked in San Diego with providing those resources to the community, and right now our community is able to keep up with the medical need. But it is part of what we do, and it's part of what we prepare for and train for. We do have some of our staff in San Diego who are currently called up to be part of the Disaster Emergency Management Personnel System, the DEMP system, and are being deployed in New Orleans and New York to help in those systems. And that's true of VAs across the country. We have personnel that train and then are called to go to other areas to assist.
Very grateful for all that work that they're doing as well. And I think from all that I know, San Diego is doing better than most places with regard to hospital beds and ICU beds and ventilators. Victoria in Dana Point, she asks, what is the status of all of the bills Congress has in progress to compel the White House to use the Defense Production Act? Do you have a count of bipartisan support for the effort? Victoria, that is a great question. I am a co-sponsor of a resolution to try to compel the president to use the Defense Production Act. And we started that resolution before the president started using the Defense Production Act. So we're happy that he did that. He's now entered into a relationship with through the DPA with GM and Philips and a few others to get them to produce ventilators. I'd like to see the full use of that. I don't know why we would hold it up for whatever it is that we would need, whatever our medical professionals need, whether it be PPE or ventilators or masks. We ought to use the DPA to its fullest extent. And we do have significant bipartisan agreement on that. My hope is that we're going to see a lot more of that very soon. Joe asks, I don't have a city for Joe, but Joe asks, I was a rideshare driver for the past 3.5 years and filed for unemployment over 10 days ago. No eligibility, still nothing, no income. How am I supposed to stay at home and survive and support my family? Again, I would recommend, go to the EDD, California Economic Development Department. You can contact our office. We'd be happy to assist to whatever extent we can to get you in touch with EDD. I know as part of our legislation, did a number of things that I hope will help you. One was expand unemployment insurance again to ensure you're going to be eligible. 39 weeks, an extra $600 a week from what the benefits used to be. And then the direct cash payment as well, depending on how much income you've had in the last couple of years, you could be eligible for that also. So please contact our office. I think that a lot of the processes that are being put in place, I'm hopeful that literally we're talking days, not weeks, before they're in place. The same is true with the Small Business Administration. Secretary Mnuchin told us this afternoon, that $98 billion worth of the $350 billion in the Paycheck Protection Program has already been approved. It's just a matter of getting all the ducks in a row with regard to the technology, because the program is going to be oversubscribed, which is why we need more money. But some lenders did a really good job, and other lenders did a lousy job with regard to the rollout of that. And the same is true state by state with some other programs as well. Paul in Carlsbad asks, given the recent announcement from Wisconsin about a delay in their primary elections, well, we saw that didn't happen, during the ongoing COVID-19 crisis, do you see any impact to future scheduled elections in California? How do we ensure a fair and democratic election process during a pandemic? I'm assuming that you asked the question prior to the Supreme Court weighing in, and for me, it's really simple. You should never have to choose between your health and the ability to vote. Simple as that. We should not be putting people at risk because they want to exercise their democratic right and responsibility to vote. And so the allegations that somehow vote by mail creates fraud or any of the rest, simply not borne out by the facts. We've got widespread vote by mail in a number of states. California, in our district, about 74% is vote by mail. California now has vote centers and sends most everybody, not in San Diego, incidentally, but in a lot of counties, and eventually that'll be the case in San Diego, where everybody will get an absentee ballot by default and then have a variety of options on how they decide to turn that ballot in. The only election going on in California that I know of is in May, which is a special election for one of my congressional colleagues up in the 25th district, which is like in LA County, North LA County, Ventura County area. That's going to be an all vote by mail per order of the governor. And look, I would hope that we're going to get back to life as normal, get people back into the workforce, and that we won't have a second wave of COVID. There is, of course, that possibility that if we go too quickly, that we could see a second wave, or even to some degree, we'll see some of it, but hopefully not anything too bad. Obviously we have to be ready if in fact there's any kind of problem in getting people to the polls. I would like to see a national vote by mail as default. And I think it's ridiculous that in some states we make it incredibly difficult for people to cast an absentee ballot. Very simple. If you're eligible to vote, I think we ought to make it as easy for you to vote as possible if you're eligible to vote. And that's how I felt before COVID. That's how I feel now. That's how I'll always feel. Thank you for the question. And we did, incidentally, we wanted $2 billion in the CARES Act for secretaries of state to be able to deal with elections and how those elections would be impacted by COVID. We got $400 million, and I think we're going to be asking for more. Glenn asks, this is going to be interesting. Why was Captain Crozier relieved on command of the TR when there had been no due process and no evidence? He released his letter to the press, and now Captain Crozier is sick himself with COVID, and he was only trying to save his crew. Well, Captain Crozier, I believe, is a person of the highest integrity. If you see the video of how the crew reacted when he left, you see that they believed that he was acting in the highest integrity. He clearly did not follow the letter of the chain of command, but in my discussions with military leadership, interestingly, Theodore Roosevelt himself didn't always follow the letter of the chain of military command, as was the case many decades ago. But look, I think now with Acting Secretary of the Navy having resigned, I hope that we recognize and acknowledge Captain Crozier was doing what he believed was best for his crew. Richard in Carlsbad. This one's for you, Dr. Smith. I've been watching the health interventions and outcomes coming from other countries and notice a stark contrast between the United States and Germany. Their fatality rate is the lowest in the world currently. I'm curious, what are we learning and adopting from those interventions?
So that's a really good question, Richard. One of the things I think that the experience in Germany points out is the value of early testing. But you also have to pay attention to how that testing has been done and to how things are evolving. Germany had testing available early and was testing a large percentage of individuals with minimal symptoms. And in that testing process, because they were testing a lot of younger and relatively less symptomatic folks, it looks like their initial mortality rates were quite low. Their experience has actually been shifting in the last few weeks, and they've had a larger impact of COVID in an older population. And so their April mortality numbers are actually somewhat higher. I think the gist of the question, though, is what are we learning from other countries? And again, I think what we're learning is that aggressive testing, as it's becoming more available and online, will help us to understand the disease and where to focus our resources. And that by testing early and using social distancing, which actually Germany was also quite aggressive about, that we can potentially slow that spread and have a reduced mortality.
Thank you, Dr. Smith. Andy Ortega sent another one by way of Colonel Skip Curtis from the Military Order of the Purple Heart. And here's his question. As COVID-19 treatments are investigated, one, prophylaxis, using azithromycin plus hydrochloroquine, we've heard about this, seems promising. Is there any effort in the VA to use this combination for prophylactic effect in immunosuppressed Agent Orange patients? Interesting. I'm certainly a volunteer to be part of using this treatment. Interesting. We've heard a lot about this and would love your thoughts.
So good questions. And hydroxychloroquine, also known as Plaquenil, has been around for a long time. It is a relatively safe drug. And azithromycin has also been around and is an effective antibiotic. The data that was originally reported, some from China, some from France, and now a little bit more recently in other countries, was not very impressive in COVID. I don't want to say that it's not useful or that it's useful. I would say that it's an area that deserves active research study, and that is going on at many places around the country right now, so we can really get to understand. I'm a scientist. I spent a lot of my career doing research, both in interventions and at the bench, and I tend to like to follow the research rather than to wing it. And right now, I would say that using hydroxychloroquine and azithromycin, either singly or together, would be winging it. And it's hard to know when you've got a patient in front of you that's not doing well what the right thing is to do. And I certainly know that there are physicians that have advocated for using those because they might work and they're otherwise well tolerated. I'm not aware, and I may just be behind, but I'm not aware of any studies that have used or reports that have suggested the use of hydroxychloroquine or azithromycin in a prophylactic sense. The data that I've seen has been in individuals who have symptoms and have disease. But I'll try and find out if there's any studies along those lines going on. I know that veterans have been at the forefront of advancing medical knowledge in many, many areas. And we have a very active group of veterans in San Diego that have been participating in the Million Veteran Program, for instance, and others who I know would step up to try and help identify what the right thing is for the country to do. So I'll try and get some more information and maybe have the congressman post it.
I appreciate that, and I'm very grateful for our friend Colonel Curtis from the Military Order of the Purple Heart. We always wish him well. Adam in Oceanside asks, for those who have become unemployed or furloughed due to COVID-19, I understand they are eligible for up to an additional $600 per week in benefits. Do you know when or how we might be receiving this? That is absolutely right. The expanded unemployment insurance is supposed to increase, as I've said, up to 39 weeks from 26 currently. And then, from the current baseline to an extra 600 a week. I would contact the EDD, California EDD again, and if our office can be of any assistance in helping direct you to that, please let me know or let our office know. The expansion also is retroactive to the end of January, to January 27th. So once the state of California, other states start processing applications, they should be able to get some back benefits for people as well. And if you're not hearing back, again, please, contact our office. We'd be honored to help. Here's an anonymous question for you, Dr. Smith. Can I renew my prescriptions via telephone? I'm assuming this is coming from a veteran. Can I renew my prescriptions via telephone? Do I need to contact my primary care provider if I'm out of refills?
So for veterans, I would distinguish between refills and renewals. Refills, typically medications that individuals take chronically, are prescribed for 6 months or perhaps a year at a time with refills. And as long as the refills are available, you can refill them at the VA by phone, or you can do it using the My Healthy Vet secure messaging site. For renewals, the doc has to write a new prescription. And all that it takes is a secure message to the doctor asking for that renewal, and they would be happy to do it. Some medications do require testing at intervals, lab tests and others. We're generally not insisting on laboratory testing right now for renewals because we don't want individuals to have to come to the hospital or to a clinic to get their labs drawn if they should be home self-isolating or social distancing. But do contact your primary care provider or whoever the provider was that prescribed those medications, and I'm sure we can get you a renewal as well as a refill.
Thank you for that, Dr. Smith. Guillermo in Solana Beach asks, recently I saw a TV report of a machine that will be deployed in the Boston area that is able to sterilize up to 80,000 medical masks within 24 hours by using a vapor form of hydrogen peroxide. Is there a plan to purchase a similar vapor sterilizer to serve the needs of the LA and San Diego area? I have a vested interest since my son works as a physical therapist in La Jolla, and my daughter is a pediatrician in the LA area. Well, first of all, Guillermo, I want to thank you and your son and your daughter for their excellent work on the front lines of this. I am not aware of a plan to acquire that type of machine locally, but we certainly have put a lot of money in the CARES Act for supplies, whether it be PPE or the respirators, the N95 masks that we need. And I was pleased to see that the president and the administration had negotiated with 3M for a huge number of masks to be manufactured by them. And I was also very pleased to see Governor Newsom announce that the state of California has negotiated for a huge number of masks to come to the state of California. But I did see that about that sterilization machine. Any plans, Dr. Smith, to get a vapor sterilizer?
Yes, actually. And
yes.
Let me talk a little bit about that.
Okay.
So PPE, N95 masks and others are generally designed as single-use devices. There are some exceptions to that, what are called PAPRs or positive airway, positive pressure devices that are more like a hood or are designed for reuse and cleaning. But most masks are single-use. But we know when there's a shortage of masks that a reused mask may be better than no mask. And so the CDC guidance has really allowed different forms of disinfection or sterilization of masks to allow their extended use or their reusage. So really all of the healthcare systems that have the capability are looking at ways that they might be able to disinfect or sterilize a piece of PPE to allow its reusage as opposed to having no PPE. That's clearly not what we desire. What we want is to have enough stock and supplies in the pipeline of masks that isn't necessary. But it would be foolish not to make sure that we have the capability of sterilizing things if that is what is necessary. The hydrogen peroxide vapor technology that Guillermo mentions is one of the ways in which masks can be disinfected or sterilized. It has been shown to be effective. The company that is making those hydrogen peroxide vapor devices is back ordered. We have one on order with them, and I know another of the entities in San Diego have as well. I believe at least one of the healthcare systems may have a hydrogen peroxide vapor device. There are a few others. There's also some hydrogen peroxide plasma devices and some others that we and other entities are exploring to see what might work. And then the other is that there are UV light devices that can also disinfect. We in fact have some of those at the VA that we're beginning to use and make sure that we can adequately disinfect an N95 mask, make it COVID free if it had been used, and that it retains its integrity to be able to be used in the future. Again, this is to create, call it a stockpile of final contingency things. That's not what we want to do, and it's not what we're doing now. Right now, we are not reusing any of those masks. But again, if we have masks now and the pipeline isn't secure, we need to make sure that we have something in reserve for the future. So that's really where those devices, such as the hydrogen peroxide vapor generators, are able to be used.
That's really neat technology. We've got about 10 more minutes. We'll get through as many of these as we can. Jean in Vista asks, is there any discussion regarding utility rates during the stay-in-place order? We expect our rates to soar with a family of 4 home all day, especially electricity, because we're working from home and our children are online through their virtual schools. I would like to see that. I think that would be a really smart thing to do if we perhaps I can have that discussion with some of my colleagues about freezing rates. I can tell you that what we did do is I contacted San Diego Gas and Electric and Edison at the very outset of this, literally the first day that it was an emergency, and they assured me that they were not going to shut anyone's utilities off as a result of this. So that's a first step, and I think utilities across the country have done a lot of that. I would have liked to see a national standard rather than having, members of Congress have to go and talk to their utilities. We did put a bunch of money in the CARES Act for help, the Home Energy Assistance Program, to help lower income households with their energy bills. So if you qualify for the LIHEAP program, you might be able to get more assistance. But I agree with you, and I will raise that with my colleagues and see what we can do. Catherine Carlsbad asks, during the last virtual town hall, you mentioned you were going to have a call with the Camp Pendleton General and would discuss whether or not their naval hospital would be used for veterans with coronavirus. Are there any updates? Thank you for watching, Catherine. I did speak with General Conley fairly recently, and we're in touch quite a bit. And he said they haven't received any orders or guidance to do that yet, but they're preparing, I think, on base and doing a really good job at it. For the potential COVID outbreak among the Marine Corps. And we're, obviously we're incredibly grateful to our Marines and our sailors for all their outstanding work. And I'm in regular contact with them. And I think like all of our cities, I joke with General Conley that he's the mayor of the 3rd largest city in my district, because Camp Pendleton really is like a city. And he's put in place many of the same restrictions that our cities have in terms of people needing, our Marines and their families needing to stay home, and a lot of the services not being open and available as they normally are. I've also been really impressed that General Conley and General Osterman have been doing town halls kind of like this. And, I'm hopefully going to get one or both of them to come and join us the way Dr. Smith has here today. I'd love to have General Conley on one of these days so you can share what's going on the base, or General Osterman to share what's going on with 1MEF. But we're incredibly grateful to both of them. An anonymous question for Dr. Smith, and we'll make this the last question. I've been using community care for pain management, such as a chiropractor and acupuncture. Now those are considered inessential medical services. What is the best way to address my pain during this time without turning to medication due to my medical history? For example, opioids, cannabis, etc. Interesting question.
It is an interesting question. Thank you for that. And it's a challenging one. It is certainly true that many practitioners of complementary medicine, whether it's acupuncture, chiropractic care, have chosen to step back a little bit during this period of social distancing. I do think that they are some of the entities that will be back online sooner than others. But having said that, they may not be available to the questioner quite yet. I would say reach out to your primary care physician and talk to them about what the alternatives are to medications. Many cases, physical therapy that can be done at home, exercise can be very effective in helping to reduce pain. What we do know is that opioids are not a good long-term strategy for pain. And so the VA, like pretty much everybody else, has been really pushing away, pushing down the amount of opioids that we prescribe, because we just know that it's not effective. But a lot of things can be practiced at home, whether it's yoga or Tai Chi, home physical therapy programs. All of those can be very effective at combating some of the chronic pain that veterans and others suffer from.
Thank you for that, Dr. Smith. And we're just about out of time. So I wanted to ask you if you had any closing remarks.
I do. I would really like to just give a shout out to my staff, the nurses, the docs that are working really at the front lines in the wards, taking care of patients with COVID-19, often trying to help individuals, screen them, and others. They're doing it in a setting where we don't know a lot about the disease, or as much as we would like, at least. And so they're putting themselves out there. And I really do think that's true both of my staff, but also of all the healthcare workers across the region, across your district, and others who are really going to work every day trying to take care of people's healthcare needs and putting themselves on the line. So I would like to just give a shout out to them and thank you for giving me a chance to provide some information to your district.
Well, we're incredibly grateful to all of them, Dr. Smith, for all of their great work, and to you for your leadership in this time of crisis, and for spending the last 90 minutes of your time, very valuable time with us and with our constituents. In the past, we've had a really great attendance at these, so hopefully that's the case this time as well. And we'll continue to do these for as long as this crisis goes on. I want to thank everyone for watching, whether you're watching on Facebook or Twitter or YouTube. We hope that you will go to our website at mikelevin.house.gov, where you'll see all the resources that hopefully will be helpful to you to be able to navigate the many programs that were enabled as part of the federal government's response, along with a lot of the local and state programs as well. I can also, as you did, Dr. Smith, I want to take the time to thank my team for going above and beyond, for responding to constituent needs and requests, for really being leaders in our community during a very, very difficult time. And my hat's off to everyone on the front lines of this, whether it's a medical professional, a doctor, a nurse, or for that matter, the people who are stocking the shelves at our grocery stores and who are driving our goods around that we're all relying on. We thank them. We're grateful to them. And I hope this was informative. I hope that you will continue to attend these town halls that we're going to keep doing, as I mentioned, as long as this crisis continues. And they'll be archived as well, and all of our former town halls are archived as well. And finally, I want to wish everyone out there a very happy Passover, a very happy Easter, whatever your faith tradition. We are extraordinarily fortunate and blessed to have just great leaders in our community working very, very hard to try to mitigate the worst of this crisis. And let's face it, this is going to be a strange Passover for those of the Jewish faith, a strange Easter for those of the Christian faith, in that we're not going to be able to spend it as we might want to with our loved ones. But we can still call them, we can still FaceTime with them. And again, I think this is a time for us all in the community to act with kindness and compassion and strength and resilience. And I know that we're going to get through this difficult time together, as we always do as Americans. So thank you for watching, and I look forward to seeing you again very soon.
Thank you.